Hello and welcome to a webinar on value-based payment for primary care and behavioral health practices. This is the 5th webinar in a series brought to you by Millennium Collaborative Care and community partners of Western New York. We are thrilled to be able to offer a candid and insightful interview with Michelle Curto from Horizon Health Services. Michelle is the Vice President and Administrative Operations Lead for Horizon Health Services. Her career with Horizon is truly admirable. She began her career 34 years ago as a counselor in the day treatment program and was promoted several times over the years to various clinical and managerial positions after returning to school for certification as an addictions counselor. Today, as Vice President of Administrative Services, Michelle is responsible for the administrative and managerial oversight and leadership across the entire corporation. Michelle graduated from Erie Community College with a degree in occupational therapy and graduated cum laude with a BS degree of social sciences from SUNY at Buffalo. She also graduated from the Kenesha Center for Entrepreneurship Key Managers Program, which focused on enhancement of managerial skills and talents. Michelle also has completed several management classes in leadership and communication through the University at Buffalo's Institute for Administrative Management. Thank you, Michelle, for joining us today as we talk about value-based care. Let's start off with some questions about, as you look back over the last 3 to 4 years, and I'm sure time has flown by, but as you look back over the last 3 to 4 years in value-based care, integrated care, and behavioral health here in Western New York, what do you see as your biggest successes and maybe your most important lessons learned?
Thank you. Thank you for having me. Wow, it's a loaded question, so I'll try and focus on a couple things. As I look back over the last 3 or 4 years, for me, when I think about healthcare reform and system transformation, what I think DSRIP did and what I think has really, as I've seen in my career, change is that we all, not for the first time, but in a long time, and I'll say in the first time, that we're all talking the same language. We're all incentivized in many ways towards the same goal. We're all, focused, in the true north, like where are we going? And we understand that it's not always just about inputs, but it's really about outcomes. And so words like outcomes and words like metrics and system transformation and true change, those are all words that I will say are different, but it also is helping us be successful because the goal is clearly defined, or the goal is defined. There's lots of clarity still that sometimes ebbs and flows. I think the other big success that I would say is the focus on getting data. Finally, we have a long way to go. Anybody that knows me or hears me at a meeting, I talk about getting access to data all the time, but it's starting. Yes, we have a long way to go, but getting data is very critical, and we've started to go down that road. We're seeing where the gaps in care are. We're communicating where the gaps in care are, and we're trying to figure out together how we can make a difference for true, healthcare, for true wellness, actually. That's the word that we start using. And then I guess lastly, what I would say is there's been lots of collaboration and partnerships that have happened, and siloed care is really not an option any longer. And yes, we all need to survive, but in order to survive, we have to have partnerships and collaboration, and all working together to not duplicate care. There's not enough money in the system. There's not enough grants to go around. Right now, I feel like there's a lot of money being infused into the system to try and figure out what sticks and what matters. But I do think that while there is duplication, right now we're all trying to figure it out, and eventually we're going to have to get better at knowing where the resources are and utilizing them appropriately.
Well, that's so, in some ways, the, saying that, we're speaking the same language, siloed care doesn't work, that we've really moved to data. In some ways, the fact that we've progressed as far as we had in 3 or 4 years is really just amazing when you look back at it. Those are pretty transformational things. particularly coming from the behavioral health perspective, I know having access to data, really the behavioral health field has really been historically left behind in that. Provided a lot of service, delivered a lot, but really was not able to show data, even as well as our primary care or health system colleagues were. So I think it's interesting that you sort of identified that as a key lesson learned. I certainly have seen that as well.
Absolutely, and I think that we joke about behavioral health is at the grown-up table now, and it's I've been around for a long time, and I've seen over the last not even 3 or 4 years, but certainly even longer than that, where the identification and realization that obviously behavioral health disorders contribute to overall healthcare and actually impact the money that's spent and the ability for true wellness. So the fact that we've moved from I guess a focus on acute inpatient care to early intervention, primary care, behavioral health integration, all of those things are, again, just, it's like inverting the healthcare triangle, right? Where before it was about, inpatient care and hospitalization. And really now that's, the end of the story. It shouldn't be the beginning of the story.
Yeah, well
prevention,
said.
Yeah, prevention, early intervention, all of those things matter. So, I think back, it seems like it's a no duh, but really, they are big successes, and they'll only get better. But those are the highlights, I guess I would say.
Oh, that's terrific. So sort of taking that as, okay, we're not operating in a silo. We're starting to use the same language. We have more data. What are you and your colleagues really working on now? What do you see next for your value-based payment work?
Mm-hmm. There's probably going to be a lot of repetition because there's a few key items that matter, and I'll say that collaboration and efforts with many partners is certainly something that we're working on. Value Network is something that Horizon is the Behavioral Health Care Collaborative, which I guess we'll talk about in a minute, but collaboration with many partners, the partnerships even at the horizontal level, all behavioral health partners working together, social determinants of health agencies working together and coming to the table, partnering with primary care practices, where we have integration of primary care and behavioral health is a key metric and a key measure of success, or a key measure of health and wellness. I think that's a huge one, and secondly, I guess I would say value, defining value. So value is a word that kind of has been thrown around, but I think we all are kind of working in many of our siloed worlds now. And as we come together, what does it mean? What does value mean? It's different for different industries. Value is different if you're a payer. Value is different if you're a medical provider, perhaps, or a social determinant provider, but looking at data, analyzing it, and figuring out what truly is making a difference is absolutely what we're working on and trying to define that. And it's kind of a moving target. We're figuring it out, and we're working on data exchange. I mean, that's going to be a huge thing. We have projects with HealthyLink, EMR to EMR. What do you call it? Integration, really. HealthyLink is leveraging some communication and information exchange with ADT alerts and making sure that we are sharing some key patient data. That's been very helpful. And just, again, our EMRs don't talk to each other. So not only is the world siloed, but our communication and our infrastructures are siloed. So there's been lots of efforts at exchange of data. And even on the horizon is, I'll say, a universal consent, so that we have one consent for a patient who understands that that patient's in the middle, and we are all surrounding him or her in their healthcare journey and in their wellness initiatives. So the fact that we're going to be able to have a universal consent in the future and be able to share information readily is pretty exciting.
That's terrific. Is the universal consent something that you're working on with Value Network, or is it something that you're working on with some of your primary care partners as well?
It's a behavioral health care collaborative initiative where it's being vetted through the state. It's almost approved. I don't know. It's like close to being approved. We haven't rolled it out yet, but that is going to be something that, again, seems simple, but will change our world once we can do that.
That's fabulous, and just one of the things, just to maybe draw some emphasis on the point that you're making. I've sat in rooms where people are talking about collaboration or talking about sharing care with a particular patient or member, and they'll all say, well, I can't get Susie to respond to me, and then the next person, well, I can't get Susie to respond to me, and that's because we're not looking at it through the eyes of Susie, right? We're looking at it as we have a need. We have a need for a consent. We have a need for an enrollment. We have a need for a contact. And what you talked about in terms of really having a universal consent is just such a door opener, and that coupled with data is something that is really going to, I think, make a huge impact in the area of value.
I mean, and then you add, Title 42, you add, the whole substance use Title 42 into that, and, then it's a huge black hole, right? And so there's some movement in that direction as well. And I think that lastly, I guess what I'll say is, I know for Horizon, and one of the things that we talk more about is an emphasis on service delivery and outcomes rather than programs or programming that we're working on. So really that people understand the why we're doing something. Why are we providing a service? Why is it important? Even if we're not getting paid for it, why does this matter? And how does it lend itself value to the program that we're doing? But we're not talking about we're in a mental health program, or we're not talking about I'm in an SUD program. I'm here to receive healthcare services, and the healthcare delivery is, whatever. But the emphasis on that is important.
It's interesting. You just almost totally anticipated a follow-up question that I had, and that is that I think whether you're in the behavioral health service area, or you're in primary care, or you're a health plan, or you're a hospital system, listening to this conversation, I think it's been fair to say that in the past, people have experienced behavioral health as a very program-driven area of healthcare, right? It's, are you appropriate for my day treatment program? Are you appropriate for inpatient? Are you appropriate for clinic? Are you appropriate for case management? We really have grown up in terms of our community healthcare system very much in the program sphere. And I was going to ask you, because you're talking about so much collaboration, sort of how that's been for your organization or for Value Network in really helping to make sure that it's not just the leadership that's understanding that, but that your organizations are starting to understand that, because I think that's hard. That's when your identity as a clinician for 15 years have been associated with a PROS program or an assertive community treatment team or a clinic, and now suddenly we're all working together around an individual member. That's a really different way of looking at that. So, have there been sort of lessons learned or observations that you might share on that?
Oh gosh, it feels like as an administrator and as a company, we spend a ton of time teaching the staff. I'll say again the why of doing something and how it lends itself to patients getting better, so we do a ton of teaching. But the other thing I'll say is that I guess that the positive spin on that is there are more resources and community supports like health homes and care managers and recovery coaching and peer services, all of those kind of things that are ancillary supports to the actual program. So it's lend itself nicely to the person might be admitted or registered in a program, but the fact that the services are wrapped around the patient and it's the walls are lessened, and we're using community supports more than ever. So it's lent itself to not talk so much about programs, but talk about resources and services.
Terrific. let's move on, and this next question is loaded with acronyms. So, so many hospital healthcare, primary care colleagues will listen to this interview. And I know if you happen to be in the behavioral health world, things like these behavioral health initiatives, like a BHCC or CCBHC, which sound like the same thing, just reversed, right?
Right.
So can you just catch us up a little bit on on what's going on with both of these initiatives and sort of where you see and how you see behavioral health playing a role in networks and various IPAs in Western New York?
I guess I'll try and not to editorialize or whatever, but I guess in general, what I'll say about CCBHCs or even in the behavioral health collaboratives, I'll talk about CCBHC first, is I think that the concept is correct in terms of CCBHC they were a demonstration project or a grant-funded project where similar to DISRIP, it's infusing large dollars into the system in order to see if transformation and overall healthcare improves, right? So similar to DISRIP, it's kind of the same thing if we just want to be, in the acronym world, kind of make it simple. But what I think about that, though, is that the problem with all of this money that's floating around in the system with CCBHCs is that we need to fix our financial model, right? The true cost of care, the true cost of good care requires a lot of money, and it isn't reimbursed in a payment model where the revenues generated from Medicaid and Medicare and all of our payers, it doesn't support the cost of professional staff, the overhead, the infrastructure to provide good programming, right? So we all are still, in the behavioral health world, we're all still relying, and it's probably true on the medical side and the hospital side as well, we're relying on these grants to help support and bolster the treatment delivery system, which is all a really great thing. But the thing that's going to make the difference in coordinating of care and infusing support services like peers and coaches and recovery coaches and aftercare and all of those things is that we need to truly be paid a reasonable rate for what it is that we do. So that's I guess maybe a little bit of an editorial around, I think CCBHCs are great, but it does lend itself to the model of our reimbursement rates are far below the cost of care. They haven't been adjusted in several years. And now with DISRIP and as a result of CCBHC, we know that infusing support services and coordinating with social determinants and providing, community supports and involving families, all of those things that we don't always get paid for, we know those matter. We know those make a difference. We have to figure out, I guess, and we know it works. We have to figure out a way where we can, truly pay the system what it costs for treating these often very sick and high utilizers of healthcare.
Yeah, so one of the challenges, just to build off of your comment, in case somebody isn't as familiar with it, is most behavioral health services have been paid by Medicaid rates that you can say they were or were not related necessarily to cost. They've been sort of there in the system and increased 3% or 4% or 5% or split a few different ways, but to your point, aren't particularly related to cost. And then sort of moving from that into across to the other mountaintop, which is where you would have a value-based payment arrangement with a payer. Right. The challenge from a provider perspective is you may have 5 payers in your geographic area, and 2 of them may think that the services that you have that you've just been describing in like CCBHC are fantastic and they're willing to pay you reasonable rates, and 3 aren't. And then how do you continue to operate, right? And how do you make it across from those 2 mountaintops from a very historic non-cost based system into one that is. And I think you described that well in terms of that. That's a dramatic challenge that's there. And we've seen with CCBHC some of the possibilities, some of the good things that can happen if we do have that infusion of money, just like I think we've seen with DSRIP in hospital systems and in collaborations. We've seen that can really fuel some amazing work. The question is how do we sustain that? And that part of the system has been a little bit slower to mature, really statewide. And I think that slowness of maturity is on the plans and, primary care providers and behavioral health providers. We're all trying to figure that out, it seems like.
Right. And behavioral health care collaboratives, I mean, they're coming together for a common purpose. Value-based care is our future. We can't deny it. And so, I think, to answer your question, you got to start somewhere. So we are starting. We start slow. We pick we're picking one or two metrics, or we're coming together and meeting with the payers to, again, deliver what we believe is value. And we sit at the table and talk about, the different terms and what value means to each of us. But at the end of the day, it has to pay for itself, or there has to be a win-win for everybody. So I do think that, there's lots of opportunities and possibilities where for us in behavioral health, we have a lot of the data because our data hasn't always been shared, right? It's been more medical based, where you're measuring cardiovascular disease and hospital admissions and diabetes and those kind of things, where we've been measuring a lot of things like medication adherence, or just people and what helps people recover or become stable. And so I think that partnership with the payers, where we are able to say, we know for sure that if we do X, Y, and Z with our population, we will see improvements. And it's some of it's scientific data, some of it is anecdotal, but we do know when we do pilot projects. So pilot projects was a big thing is a big thing in behavioral health, right? Let's start little, let's start slow with an identified population, and that's how we come together, where we can show and demonstrate that we can and do make a difference. So pilot projects work a lot.
Maybe to do a little bit of an advertisement for Value Network IPA and for the Behavioral Health Collaborative. If we do have a hospital health system, primary care practice that's listening to this, that's maybe not had a lot of contact with behavioral health, but has some interest in it. One of the added nice pieces of that being in existence is that's a place where somebody can reach out and start to have a conversation about how they may look at including behavioral health providers. If they're not sure sort of who they should be working with, that's an entity in Western New York that they could reach out to. Yes.
And I think I don't know the statistic enough, but it's the summary or the intent of the statistic is really when you look at the hospital admission reasons, the number one reason for admission a lot of times is accidents or falls or something like, and oftentimes, and in addition to something, oftentimes it's related to behavioral health disorders, or somebody not taking their medicine, or being intoxicated, or things like that, where now that we have a reason to really do a deep dive on, yes, you came here because you had a fall or a broken bone or whatever, but what was the real result, or what was the real reason for all of that happening? And behavioral health disorders, so I'm probably not saying it right, but the behavioral health disorders are often behind the reason for many hospital admissions, and that's being. No, I think you're saying it.
You're saying it well, and in fact, probably as we're having this conversation, another thing that we've learned along the way is the importance of coding, right?
Yes.
2 or 3 years ago, coding was something that somebody down the hall did, on a piece of paper, on the computer to send off a bill. Now I think we've realized how important coding is, how important attributed lives are and denominators, and and if you're really going to change some of the healthcare outcomes, you have to make sure that you're you're actually looking at root causes. And I think your point does a good job of really, identifying that when you do look at emergency room visits, and particularly ones that are potentially preventable, you will oftentimes find a mental health or substance use, root cause there. And so how do we think about that in terms of our coding and our data, and then how do we collaboratively act to find solutions for that?
Yeah, again, so data continues to be a theme that weaves through here, and the other thing is really just using data to drive the clinical initiatives, and also to do and once you have some data, you're able to then even do deeper dives in predictive analytics, which is what we're all that can be fun too. That's just, sometimes it's just amazing when you're trying to do some of the predictive stuff as a result of X, Y, and Z, ABC is likely to happen. It's fascinating.
Great. Well, so somewhat into into the future and into more technology, and I know there's been some recent developments in January and February on telehealth and population health as it relates to behavioral health, and there are some draft regulations out. So I know some of that is still in play, but I wonder if you could share how you or your colleagues are really using telehealth, telepsychiatry. I've heard it described as telemental, but in your population work, are there things you're doing now, or are there things you're particularly interested in doing as you look at value-based care?
Absolutely. The meeting I was in just before this was a telehealth meeting where we're going to launch that. We just got a grant with America Well. And we're going to do, so it's a platform that allows us to do tele in a big way. And we're going to have a kickoff meeting, and it's absolutely, necessary, where we're in a system where access to care sometimes is difficult. The stigma for receiving care is sometimes still there. The expense of care, so tele offers somebody a different option and maybe a lesser option, and rather than going through their insurance. We haven't quite figured that out yet, but OASIS and OMH are in the process of promulgating their regulations, and they're almost there. OASIS has regs, and OMH is, I think they have a few more days for comment, and then they will probably promulgate those out. But we plan on definitely launching telehealth in a big way. We're anticipating that it will help us with our psychiatry shortage, and our cancel rates, and our call them our show rates or no show rates. There's so many different benefits to doing tele. I think it's really going to be an awesome vehicle to infuse some access at all levels, because staffing is a problem. Both workforce issues are huge, so the fact that we can provide more access is going to be very helpful.
Well, that's great. I know in the most recent Medicaid update in February that the health department put out there, having the expansion of sites where you can do telehealth, so that it can be in a variety of creative locations, as opposed to actually in a licensed site or in a licensed office, has really opened the door, I think, for us to expand this in really meaningful ways. Because in part for the behavioral health population, when the originating site or the destination site had to be an office, that you almost found yourself saying, well, if we could get the person into the office, we wouldn't need telehealth. Right?
Exactly. But and that's the funny, not so funny part about our industry, right? I mean, there's always, the intention is always there, but sometimes the devil in the detail makes it, it's just, you have to walk away. It's just too hard to implement. So that was the hub and spoke model. So that going away, allowing, greater access, the fact that patients can put this on their phone. And I'm going to say something, it'd be something as simple as, if I have this app on my phone, I could go in my car, my lunch hour, and, have a brief session with my counselor if need to, or, I can stay home in my pajamas because I have difficulty with transportation, I just had surgery, or I, just don't feel like dealing with the world today, but I still have access to care, and that helps my overall wellness. Again, we keep talking about, rather than illness, is we're focusing much more on and talking about how what it is that we have to deliver contributes to overall health and wellness. So this totally fits that.
Well, that's it. So we will be on the lookout for an announcement about America Well. That sounds like a really exciting prospect, and we look forward to hearing more when you guys are ready to share that. But it's great to hear that you're looking at expansion there.
And this is, this was a grant that we applied for. And once again, we're grateful for grants and money being infused, because again, project kickoff and implementation and administration and early, the early growing pains, they all cost money and drain on resources. So, we definitely, are grateful for money being infused into the system. The editorial earlier was really just more about, and in general, we need to continue to lobby and advocate for making sure that, the rates have been flat, and that we need to continue to, and for us to be able to attract new staff staying in our area, staff coming to our area, we have to be able to have those APG Medicaid rates move up from, I think the last increase really was like 2012 or something like that.
Right. So let's round out our conversation around social determinants of health. So this is something that we talk about a lot. It certainly is a buzz around the water cooler, and you can't almost go 5 feet without running into an opportunity to listen to a webinar, or go to a conference, or be inspired by some community-based organizations who are offering social determinants of health. I guess the question about this, though, is, sort of, are we doing enough? And sort of how can we move from talking about social determinants of health to really being able to better integrate them into what we do?
For me, when I think about that, it reminds me of, the behavioral health industry, where, again, we were not at the table. I think what I see more and more is, how we're doing enough is through collaboration and partnerships. I think the social determinants of health agencies and the services that they deliver and the supports that matter, they're being acknowledged. Many of them, I think, and I don't work in that industry, and I have not worked in that industry, but my thought process would be is that they're used to being funded by grants, being funded by they don't necessarily have an EMR or electronic medical record. They don't do billing for their services. So they haven't been in the traditional way part of the healthcare delivery system. I think now. What I see is they do have a place at the table. They are treating and supporting and stabilizing some of the most difficult patients. We have very sick patients, some of the most hard to reach patients, and the fact that we're talking about how, once again, not only behavioral health, but social determinants make a difference on somebody's ability to achieve health and wellness. And until we start dealing with social determinants as they relate to overall health and wellness, people aren't going to get better, and healthcare costs are going to not go down. So I think that they have an opportunity. I'm not going to say for the first time, but I see them having an opportunity in the healthcare delivery system now more than ever, because of partnerships and collaboration and the realization and the talking about it takes a village, right? And the patients in the middle and all the supports need to be around them. So, that behavioral health care collaborative value partners, value network, social determinants are part of our network if we're going to deliver value and we're going to be successful. We knew that at the beginning, and so they're part of who we are as value.
I'm not sure that everyone who's listening to this webinar, may not know that, the Value Network and many of the organizations that have provided the public behavioral health services, also deliver housing and, social supports and advocacy and employment and, educational supports. So if you were to run down, like the Kaiser Family Foundation definition of social determinants of health, and then you were to sort of lay that up against the Value Network, sort of the full portfolio of all of those organizations. There's a lot of those social determinants in those organizations, as well as what's delivered by a community-based organization, which is a particular strength.
Right. And again, if I think more and more those agencies through their partnerships or being on part of these collaboratives are starting to focus on data as well. So, as we're all talking, they can help be successful and solidify a place at the table in the future for their agencies, because they have to know, again, they have to start talking about what value they deliver, and because data matters, they're all forced to start to collect it differently to determine, what is it that they do that matters? What is it that they bring to the table in joining these collaboratives that make a difference?
Oh, that's terrific. Well, Michelle, I would like to thank you for taking time out of your day to share your insights and thoughts with us. It's been great to catch up and hear the kinds of things that you're working on and hear the progress that's been made, and to almost have a pre-exciting announcement that there's more good stuff coming down the road. So I really thank you for your time today.
Thank you so much. It's been great.